innervates the sternocleidomastoid muscle and the trapezius muscles. The trapezius muscles are very easy to test. That's where I had you shrug your shoulders up, and I push down to try and overcome you. The sternocleidomastoid muscle is the one that actually has the strange insertion such that the right sternocleidomastoid muscle rotates the head to the left. So that the way I test that is I generally have the patient put his chin against my hand and press against me, resisting my movement back the other way. And while I do that, I'm palpating the right sternocleidomastoid muscle.
That movement is confusing to a lot of students and practitioners.
The final cranial nerve is the hypoglossal, the 12th cranial nerve, which controls the tongue. And again, that's a difficult one to test, but basically I just ask the person to stick their tongue out, move it side to side, and see whether they have symmetric movements at equal rates in both directions. The next major piece of the examination is the motor examination. There are a lot of different components to this that, again, will be tested in different orders by different people, but for discussion's sake, it's useful to talk in the order we're about to go through. So the first thing is just the muscle tone, or the resistance of the muscle to passive manipulation. So with any patient, what you try to do here is have the patient as relaxed as possible as you just move the limb for them. And in fact, you're moving it a little bit for me right now. So you'll often have to coach the patient and say a number of things like, just pretend you're in a sauna, just pretend you're a piece of a limp spaghetti, or various things. But the idea is not to have the patient assisting, but just to let the limb be completely relaxed as you move it, and you test to see whether there's any abnormal resistance to the movement.
I noticed, Doug, when you tested me earlier, I was tapping my other limb against my leg.
Yeah, the reason for that, there's two reasons. One is that one form of abnormal tone is cogwheel rigidity, in which you will get kind of a ratchet movement of the limb, and that is produced more easily if the person's distracted. On the other hand, if the person's having difficulty relaxing, that distracting movement on the other side often helps them relax more also. Mm-hmm. I usually actually am trying to palpate the joint with the one hand as I'm moving with the other, and I'm doing the same thing here. I do that examination of tone for the most part at the elbow and wrist in the upper extremities, and at the knee in the lower extremities. If somebody's on an examination table, what's often helpful is just to have them lying on their back, and you quickly lift the knees up. In a normal person, the heel should just drag smoothly along the table, whereas somebody who's got increased tone in their legs will have incomplete flexion of the knee with gravity, and so the heel will actually come up off the table. You can do something similar in the upper extremities of just flopping the arm around like that, which is normal. The next thing on the motor examination is to test pronator drift, and that's where I had you put your arms out like this and close your eyes. It's a very sensitive test for certain abnormalities of the nervous system in which one arm will drift slowly downward while pronating.
Yeah, I noticed that you had me spread my fingers apart, while I actually test with the fingers together, because one can find with subtle weakness there actually will be abduction of the small finger away from the rest of the fingers as a very sensitive sign of upper motor neuron weakness.
That's a good point. The next part of the examination is to actually formally test strength in individual muscles. And this is something that's often confusing, not so much confusing, but difficult for students because they're trying to remember exactly which muscles to test, and they're trying to remember in what order. And as I've said already, the order doesn't matter. It is important to try and have a good screen of a number of different muscles. And for me, the easiest thing is just to divide the limb into different joints and to remember that at just about every joint you can test flexion or extension. The other thing that's difficult for students to remember sometimes is that you want to isolate individual muscles as much as possible. So a student who is trying to test flexion of the arm might come up to a patient and say, bend your arm up like that, and test there. And in so doing, they're also letting the patient's shoulder, wrist, and elbow muscles all come into play. If they find weakness, they really don't know where the weakness is because they haven't isolated it. So it's best to have one part of the joint just proximal to the muscle, stabilized with your limb as you're testing just distal to the joint.
Right, Doug. There's a lot of subtlety to testing the strength. I do some things quite a bit differently than you. Among other things, I will position the joint so that other muscles can't assist. In this position, only the biceps will assist with contraction of the arm, whereas if there's a turn of the arm at the elbow, the brachioradialis can actually compensate. Secondly, I try to have gravity play a role because if someone is actually quite weak, this is a way I'll know if they're at least 3 on our MRC testing. Something else that I do that's a bit different is try to use a similar part of my limb to test the patient's limb. For example, in testing the index finger as it abducts, I would use my own index finger abducting to press against the patient's to see if I am stronger than them or we have equivalent strength. I don't really know how strong an index finger should be versus the strength of my entire hand.
That's a good point. The one other point that I find to be very difficult for people to learn as far as testing strength is just how to make the whole exam fluid. It's very hard, especially with patients who are confused or tired, or even patients who don't speak the same language as the examiner, to get them to understand what you're trying to do when you say, please move your limb in this direction or that direction. And it's best to have kind of a standard prototype that's used for every single muscle that then once the patient does finally understand it for that muscle, they can easily translate to different muscles. So basically the prototype I use is put your limbs in position X and I have them imitate me, and then I say, don't let me move you out of that position, rather than trying to explain, now move your hand over here or down there or so forth. The next part of the motor exam is to test coordination. And for that, there's 3 major tests that I do in the upper extremities. The first is the fine finger movements, in which I just ask the person to tap one finger on the thumb as quickly as possible. The second is rapid alternating movements, in which I ask the person to alternately pronate and supinate the hand as quickly as possible. And the third is finger to nose testing, in which I ask them to touch their own nose and then touch my finger. And I ask them to do that as I move my finger in various directions, because I don't want them to just get into a kind of a train in which they don't need to use their nervous system to continually readjust position. I want to be sure that they are able to point to a target accurately as the target moves. In the lower extremities, the major test of coordination I do is the heel to shin testing, where I ask you to extend your one leg, put the heel of the other on the knee, and run it smoothly down the shin. And with all 4 of these tests, the 3 in the arms and the 1 in the legs, the most important thing of all is an asymmetry from one side to the other. It's hard to know what exactly is normal for any one person to be performing in this task or one of the others, but you can always use the person as their own control to compare one side to the other.
Right.
The next part of the motor examination is the gait. And that is actually very useful because it's much easier to judge how hard a person is trying when they're doing something that they actually do every day than when you're giving them these kind of artificial tasks. And it's important to watch just their casual gait. In fact, it's often helpful to watch that even before you've started the examination so they're not aware of the observation. And then it's very helpful to test as they walk on their heels, on their toes, and in tandem, which is where I had you walk with your heels touching your toes as if you were on a tightrope.
Another thing that I do, Doug, as part of my routine screening examination is ask the patient to arise from the chair without using their arms. I ask them to bring their arms in front of them so that they cannot push off the chair and then start to stand up from the chair. This isolates the gluteal muscles, which are very proximal muscles, and if there's any subtle weakness whatsoever, the patient will need to bring their arms down and push on the chair arms to arise.
The next part of the examination is the deep tendon reflexes. This also is something that many students have trouble with. It's probably the one part of the examination that's most associated with neurologists and gives non-neurologists the greatest pause. There's really nothing to say other than practice makes perfect, but there are hints that can be given. One thing is to be sure that you're actually tapping on the tendon itself. If you tap on the bone just above or just below, you're not going to get the reflex elicited. Another thing is that the position of the joint makes a big difference, that the best position is generally to have the limb right in the neutral position, which often means about 90 degrees, and to have the patient as relaxed as possible. If the patient is tense, then you're not going to be able to elicit a good reflex in many cases. If the joint is completely at one extreme, especially the ankle joint, then there too you're not going to be able to get any further contraction of the muscle and you won't see anything. So with the ankle reflex in particular, I tend to cradle the foot in one hand, thereby allowing the patient to rest so that they don't have to actively dorsiflex the ankle. But as I'm cradling the ankle, then with the other hand I'm tapping the reflex and I can get a good contraction and I can see a good movement. That's the ankle and the knee are probably the two most commonly tested reflexes and most important in the lower extremities. In the upper extremities, it's the biceps, brachioradialis, and triceps. And there too, it's best, both biceps and triceps are pretty well tested by having the limb at about 90 degrees or a little bit more relaxed. And then there I often actually have my thumb on the tendon and hit my thumb in order to be sure of the correct placement.
When we consider comparing side-to-side symmetry, it's very important with reflexes to have the limbs symmetric while they're being tested. So however one decides to position them, both limbs should be positioned the same way when bringing out the reflexes.
That's right. The other part of the examination that is in the same category as deep tendon reflexes is the Babinski sign, or the plantar response. This is a response that is obtained by stimulating the sole of the foot with a somewhat noxious stimulus. It's typically used as a tongue blade or a key, and taking it along the lateral surface of the foot and then gradually moving up and then kind of producing a J stroke, so that as you get to the base of the toes, you move medially on the foot and you produce this kind of J stroke. And what a normal foot will do is to flex, especially the big toe will flex down. In the abnormal response, or a Babinski sign, which is by definition the abnormal response, what happens instead is the great toe extends and the others fan out. But the most important part of that response is when you see the great toe extend. There's superficial reflexes also. I don't know if you tend to test those or not.
Only when it's indicated.
The final part of the examination is the sensory examination. There's 4 primary modalities that are typically tested: light touch, pain and temperature, position, and vibration sense. Light touch sensation is another one where you can get very sophisticated about it, but for practical purposes, I usually find that it's adequate just to use a very light touch of my finger, and again, to compare whether the person feels it equally on the left and the right in corresponding parts of the limbs. I generally, as part of my screening examination, only test the distal, the hands, the toes, and the fingers. If everything is normal there, I don't proceed more proximally. Do you do anything more proximally?
Well, not with the light touch so much, but when we get to the cold and pain perception, I do.
Okay. So with the light touch, I just stimulate lightly. The other thing I usually do as part of that examination is double simultaneous stimulation, in which I will ask the person to identify where the stimulus is coming, and it will either be their left, their right, or both. And with certain lesions of the nervous system, you can have a patient able to detect things if it's just their left side alone, but if you stimulate both sides together, they will only detect the one side and extinguish the other. The next modality I test is pain and temperature, and there I usually use a safety pin where I can apply either the sharp part or the dull part, and I mainly use the sharp part because the dull part has already been tested when I tested light touch. So I'm only including the dull as another control to be sure that the patient is paying attention to me. And there, again, I just ask them to identify which side of the safety pin I'm using and whether it feels the same in corresponding parts of their left and right limbs.
If you use a safety pin, make sure it's a new pin for every patient. I actually don't use a safety pin that often. When I test pain and temperature, I test the temperature actually. I use my same tuning fork and I use the flat end, which typically feels cold. I'll then compare side to side to make sure the perception of cold is the same on both sides of the feet and the hands. I'll also test distally as well as proximally to see if there's any stocking glove change in the perception of cold.
The next thing is position sense, where you saw that I took John's finger or thumb and I just moved it up or down and asked him to identify which direction it was moving. You'll notice that I have my own fingers on the sides of his thumb rather than on the top and bottom because I don't want to give him any clue other than position sense to figure out which way the thumb is moving. If I had my fingers here, then depending on which surface he felt the pressure on, he could actually conclude the direction of movement without having intact position sense.
Right, Doug? I do this a little differently than you do. Occasionally I will try to be somewhat quantitative and determine is it a small amount of movement that it takes for the patient to determine which way the joint is moving versus a large excursion of the joint. Another thing I will do that is sometimes taught to be more sensitive is to move the joint back and forth in a number of directions and then leave it either up or down and let the patient determine at that range where the joint has been left.
One other thing that should be said about this testing is that if you do find that the person has a deficit with a distal position sense, it's usually worthwhile testing at more proximal joints to see just how extensive the deficit is.
Right.
The final primary modality is vibration sense, in which I just take the tuning fork, apply a very small amount of pressure to get it vibrating very lightly, put it on the thumb or the big toe, and ask if the patient senses it. And here too, usually with one of the 4 locations, I actually stop the tuning fork so that the patient just doesn't get into a routine of saying yes, 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 yes.
This is another area where I do things a bit differently. I have the vibrating tuning fork and it's on one of the bony prominences. I ask the patient to tell me when he or she can no longer feel it vibrating, and then I count how many seconds I can continue to feel the vibration to give me some mode of following over time if the patient is worsening or improving compared to my own index finger.
In addition to those primary sensory modalities, there are things that are considered higher level sensory function, and that's what I was testing when I wrote numbers on your fingers. That's graphesthesia, and stereognosis is the ability to detect what kind of an object somebody has in their hand without actually looking at it. I don't really have anything further to say other than you can check and see whether there's an asymmetry there also.
Right.
The final part of the examination that we haven't really discussed in blow-by-blow detail is the mental status examination. There, I really have just a couple points to make. The first is that it's something that many students have a tendency to think that there's one test that correlates with a given function, that there's a center in the brain for language, and that if you do a given test that you will thereby have tested that function. And unfortunately, the brain's much more complicated than that. there's no way to isolate individual functions. The best you can do is to give a whole bunch of different tasks to the person that will require a lot of different cognitive processing. And by seeing the pattern of things that they may have problems with, you can then draw conclusions that all of those tasks seem to require language processing, or all of them seem to require abstract thinking, or what have you. And if you go back to that section of the tape, I typically will do a mental status exam during the reflexes because it's a way to distract the patient and to relax their limbs. If you go back to that section of the tape, you'll see that I did actually screen language function, memory, calculations, and abstract thinking with questions like similarities and differences between different concepts. But any one of those tasks was not isolating that function. If I asked John, what's the difference between a baby and a midget, obviously you need to have some language function in order to answer that question. You need to have some degree of memory of what exactly a midget is, and you need to have some abstract reasoning. Again, if you go back to the text that's provided and the tasks that were given in that part of the examination, I think you can pretty well put those things together. So that's a description of how to do the different parts of the neurologic examination. And what you might want to do at this point is to go back to the first part of the tape and again watch how the pieces all fit together in one kind of fluid movement. And the document provided to you along with this tape gives you some numbers for each individual component of the examination if you prefer to go back and review exactly how in practice the reflexes were all examined or how the mental status was done. Refer to that document and those sections of the tape, and just feel free to keep going back and forth. John and I would like to thank you for having listened, and hopefully you will feel comfortable doing a neurologic examination.